So here's the number one reason that Lyme disease tests fail. They're based on this outdated technology from like the 90s. And, they actually miss nearly 50% of all true infections. If you've been told that your Lyme test is negative, but you still feel terrible, listen closely because this video is for you. Today, I'm going to explain why one approach to Lyme disease testing has really totally changed the game and why the CDC updated their Lyme testing criteria for the first time in over 30 years. Hey, I'm Dr. Tom Moorcroft, and for over the past decade plus, I've specialized in diagnosing and treating complex chronic illnesses and specifically focusing on Lyme disease. And a huge problem that I see every single day is patients who have been suffering for years have been missed because their doctors are using these traditional Lyme tests that are antiquated and they've misdiagnosing the infection. And furthermore, one of the biggest issues is Lyme's a clinical diagnosis supported by lab data, and these doctors need to start making the diagnosis so that we can help alleviate your suffering. The other thing is we have to understand that testing is super important in this field, and it really helps us so much in really nailing down the proper diagnosis. So today, I'm going to walk you through the Lyme immunoblot. We're going to talk about what it is, how to interpret it properly, and really, I want to talk about why a recent FDA approval and CDC guideline change is making this test an essential tool for Lyme disease diagnosis. So, one of the biggest problems is people ask, why do these standard Lyme tests miss so many cases? They've heard about it in the news for friends, or they've read it online, trying to make heads or tails of all these different stories that they're hearing. In 1994, there's this Dearborn conference where all these experts in Lyme came together working with the CDC, all the top clinicians, all the top researchers, and they came up with this, what we call the two-tier testing criteria, right? So we start with an antibody screening test, and that's often called an ELISA or an EIA. There's a few other kinds as well. But if that's positive or indeterminate, it's in the gray zone, something's there, it shouldn't be, but it's not completely negative, well, then we do what's called reflex to a Western blot for confirmation. And when you look at the blots out there, there's Western blots, immunoblots, Lyme blots, pretty much anything that ends in blot is really going to be the same type of test. However, there is one, and this is the one that's making all the news and changing the diagnostic criteria. So we're going to dive into that pretty deeply in just a moment. But before we get there, we have to think about this testing strategy and what was it for? And why are so many people saying that that approach commonly fails? Well, one of the things we have to understand is that this was created for research purposes only. What does that really mean? Well, in the end, what they were trying to do is say, if we're going to make public policy, and we're going to change we're going to get good research dollars, we're going to, look at epidemiological data, and we're going to make decisions that are going to affect the entire country. We don't want to be including people who don't have Lyme, right? And that's one way to do it. That's a research-based criteria. On the other hand, we have clinical criteria. So when we're researching and we're making public policy, we don't want to be over-calling a disease because then we might misallocate funds. However, on the other side, in a clinical situation, we have to err on the side of the patient. What happened was such a problematic situation, and there's actually several things that come out from it. One is we put research criteria in the clinic. And if we assume that the research criteria is good for research, which you'll find out in a minute, that ain't true either. But if it was, if I do this in the clinic, what I'm doing is I'm erring on the side of missing the diagnosis rather than sitting down and making the proper clinical judgment based upon the unique individual sitting in front of me. So by everybody saying you got to follow the CDC testing criteria, what we did was we took the power out of the hands of the licensed healthcare professionals and we put it in the hands of a bunch of paper-pushing researchers. Now, what happens? Patients who truly have Lyme get missed. Now, we have other problems. If you look at the meta-analysis, or when people have researched and they've looked at all of the different papers out there evaluating the two-tier testing criteria, we have some problems. And one of them is that if you look across the board at any point in infection, it's known to miss upwards of 44% of true positives when we follow this testing approach. So the problem with that is if you took 200 people with Lyme disease, we are going to miss 88 of them that are truly positive by applying research criteria in the clinic. right? Now go back and look at research. I mean, a handful of years ago, the CDC said, oh, there's like 25,000 new cases of Lyme every year. Then they said 36,000 new cases. Now they're almost at 500,000 new cases of Lyme every year, because what they realized was their research criteria wasn't all that good. So let's dive in a little bit more deeply. The other problem is in early disease, where we rely on that antibody screen, that ELISA test early. One of the problems is people order it too soon. In the first week or two, and often even the first 3 or 4 weeks, we don't see antibody conversion. If someone has a rash in an endemic area and it's a Lyme rash, then they have Lyme disease, diagnose them and treat them appropriately. Now, on the other hand, if we order the test too late, then that test isn't going to be accurate either. And so the problem is early diagnosis and early treatment is crucial. When we rely on this testing strategy, that's where we start to screw things up. We tell somebody they have Lyme, they start doxycycline, and a day or two later we get a negative ELISA, we tell them to stop. Problem is, we just blunted their antibody response. We blunted a few symptoms. They get about a week or maybe a month where they're feeling a little bit better, but now you may not have a rash. Our testing will probably be negative from that short course of treatment if it were applied at the right time. And then the other part of the problem is now they're gonna have symptoms come back in a few weeks or a few months. And everybody's gonna go, oh, you have like acute fibromyalgia. When the reality is we made a diagnosis and then we let some politicians and some, research fanatics who are trying to get tenure tell us how to treat a patient in front of us. And that's a bunch of horseshit. We need to be treating the person in front of us using the very best clinical approach as well as the best scientific approach. And let's dive into that even more deeply right now. So one of the things is the ELISA test or any other antibody screen, its efficacy depends on when we actually, do the test. The other thing we have to think about is the confirmatory test, a standard, Western blot or Lyme blot typically relies on a laboratory strain of Borrelia burgdorferi, which is the causative agent of Lyme disease, called B31. So this was chosen decades ago for convenience, right? It's not even a wild strain, and it's not really representing, one, all of the Borrelia burgdorferi strains that can cause Lyme disease. It's also not covering any of the non-Borrelia burgdorferi Borrelia species that cause Lyme. And we know about Borrelia californiensis, we know about Borrelia mayonii, and even in Europe and now a little bit in the US, Borrelia azellii and Borrelia guarinii. So we have and there's emerging, Borrelia species that lead to Lyme disease that aren't going to be picked up on this. In fact, I remember back 2012-14 time, myself and a couple colleagues, we published 4 of the first 24 cases of Borrelia miyamotoi in the United States. And these were among the first 73 cases of human infection published in the entire world. So what's really interesting here is over the next 2 years after the original publications of those 73 first human cases of Borrelia miyamotoi disease, researchers went back, we found over 300 people where we had stored blood samples. We tested them because in the past we said they thought they had Lyme disease. The doctor said, oh, you don't meet the rigid research criteria, so you have it's all in your head disease. Then it turns out that despite knowing for over 30 years that Borrelia miyamotoi and Borrelia burgdorferi were in the same exact tick, and the tick, at least in the east coast of the United States, the Ixodes scapularis that transmits Lyme, has Borrelia miyamotoi, but we just said, hey, it gives you Borrelia burgdorferi, but not miyamotoi. Turns out that was not correct. Part of the problem is then we got 41 bands, which are pretty non-specific, that they were positive, and it turns out that, the doctor was partially right. It wasn't Lyme disease, but it was Borrelia miyamotoi disease, and we didn't know it because we were not, one, we weren't far enough along in our scientific understanding, but we put our heads up our butts. To be honest, how is there a strain of spirochetes that's almost identical that one is getting transmitted and one's not? I mean, we really should have looked into that a lot more deeply. So the standard Western blot is not only missing different Lyme-causing strains, it doesn't even look at Borrelia miyamotoi or any of the other tick-borne relapsing fever species. So ultimately what it means is that if you're infected by not Borrelia burgdorferi B31 strain, the likelihood of us picking it up on this testing methodology is very low. So why am I talking about an immunoblot and it being superior to these other tests? Because a moment ago I said, hey, most immunoblots and Western blots are about the same. Well, in order to understand this, we have to take a little bit of a side journey here. And one is, last November 2024, the FDA cleared the Igenex Lyme IgG immunoblot. The CDC actually changed the 1994 Dearborn Conference criteria from we have to have the two-tier testing to we have to have an FDA-cleared test. And FDA clearance is essentially approval for a test. So basically what happened was we still need to do the two-tier testing, but now we get into the immunoblot, right? Before we dive into what that really means, I wanted to give you another piece of information that's really exciting. In July 2025, the FDA also cleared the Igenex IgM immunoblot. And now this is where things get really interesting. So as a starter, like I said, most of these blots are about the same, but Igenex did it a bit differently. Their immunoblot technology uses highly specific recombinant proteins that significantly improve the accuracy, reducing false positives compared to the traditional Western blot. However, maybe even more importantly, because it's always important to not have false positives whenever possible, but the other part is we're alleviating so many of the false negatives. So now, rather than some random research criteria, we have what Igenex did was they went back to the FDA and they not only proved non-inferiority of their test. So when you look at FDA clearance of testing or approval of medicine, we just have to prove that the thing we're bringing to market isn't any worse than anything else out there, which to me is the stupidest bar on the planet. Hey, like all that does is lead to corruption in big pharma, because as soon as somebody else has a generic med, they go make another one that's no better, but they get a patent, yada, yada, and they say it's better. Most of the time, it's not better. Same thing with testing. But what was different about what Igenex did was they actually had the criteria changed because they proved superiority. They were better than the existing testing that is already approved at finding and confirming known positive samples. So in English, that means we have higher accuracy, less people missed. And so how did this happen? Well, part of it was they went super high definition with these recombinant proteins. And that's really nice because when people are reading them or machines reading them, if there's blurry stuff, your immunoblot, you're going to be, is that positive? Is that negative? Here, it's like, boom, it's positive, boom, it's negative, or there's a gradient in there called indeterminate, right? The gray zone. But it is clear that it's not nothing and it's not as dark as it's positive. It's very high fidelity. And it's important to understand that, most of the labs and any test ending in blot not only are outdated and probably going to miss a lot of these positive cases because they rely on that B31, but the other thing is they're going to miss all those other species. And this is what was really cool about what Igenex did. Not only do they include all of the known Borrelia burgdorferi strains, right? But they also include the other Lyme disease causing Borrelia species. So that to me is totally game changing in the clinic. Now, one of the other things that a lot of people have heard about is that, the CDC criteria and most of our labs aren't reporting all the Lyme bands. And like 31 and 34 are super important bands. These are outer surface proteins on the bacteria that spirocate the Borrelia species that's causing Lyme. So those are crucial to have in there. Now, in the past, they said, they might be cross-reacting, or the 31 could cross-react with people who've been vaccinated. There's less than 10,000 people ever vaccinated, but that vaccine was made based upon a 31 kilodalton protein. Because it's so specific to Lyme disease, there were about a third of the people who got that crazy vaccine that had Lyme-like symptoms that we couldn't cure because it was stimulated by this antigen that's so specific to Lyme. So rather than take their vaccine off the market and then work on making it better and then also improve our testing and then doing this crazy thing called talking to your patient and going, hey, have you been vaccinated? There's only 10,000 people in the United States. Why don't we just ask? But instead of doing that, we just threw it out, right? So the problem is 31 and 34 have been shown in the FDA review of the Igenex data that these are super important. So they're back in. right? So we've got the 23 kilodalton band, we've got the 31, the 34, the 39, and yes, that 41 is still sitting in there, and there's also a 93. Those two can be helpful, but those other first four are super important for this. These are finally back in. Now, the other thing is the old CDC style Western blot or immunoblot criteria actually include 4, upwards of 7, depending upon which researcher you read, bands that are not even specific to Lyme. So we could tell you you have Lyme and you don't. Now, in my case, most of the time, the situation is someone with Lyme, truly with Lyme, has been missed. But on the other side of that, the issue we run into is that there are people out there who get diagnosed with Lyme and don't have it. And I don't really care what you have. I just need to know what it is so I can help you get better. So if I'm thinking it's Lyme and you're not getting better, maybe it's because they use the outdated criteria. So this new high definition approach is so important. And what's really interesting is they're improving sensitivity, the ability to find true positives without losing our specificity. You know, and a lot of times we talk all this in medical school about it, like how long, you know, what does sensitivity and specificity mean? Ultimately, they're fancy ways of saying, are we getting people who are truly positive? Yes or no? Are we calling people who are, you know, are we really, if we're saying you're negative, are you truly negative? Because we don't want to call you positive unless you are, and we don't want to call you negative unless you are. With this upgrade in our, not only our testing strategy, adding more bands, requiring rather than, you know, 2 of 3 bands in the IgM and 5 of 10 in the IgG, we're looking at more bands. And we're also saying we're going to look at highly specific Lyme bands and use them for diagnosis. So that's a huge win. So ultimately, with this new testing approach, you know, if we're saying you're positive, you most likely truly are. No test is perfect, but we've raised the bar so much with this. And whether it's Borrelia burgdorferi or another Lyme-causing Borrelia species, with the Igenex test, you're actually going to be able to pick up all of them. So one of the big questions so many of the clinicians that I train in the Lyme disease practitioner certification and mentorship program is really like, how should clinicians actually interpret these in real practice? Now, this is the essential point. If a patient has symptoms that are highly suggestive of Lyme disease and their standard Western blot, whether it's like at Quest or LabCorp or some other community-based, you know, conventional lab setting, if they clearly have Lyme-specific bands, like the 23, like the 39, then you really don't need to retest a Lyme specialty lab. You've got your answer. Trust your clinical judgment and look at these bands very clearly, right? Don't delay medically necessary treatment just waiting for specialty labs to confirm what you already know. It's really helpful to understand that there's no perfect test, right? Lyme disease also likes to hide. It can go hide in immune privileged sites. It can hide in biofilm. It has round body or cyst forms. So these are mechanisms to evade your immune system. The biggest thing that we haven't touched on yet is all of these blots and these antibody screens require your immune system to be seeing and recognizing the bug. So if it's been there a really long time, your immune system might forget about it. If it's in hiding, it might forget about it. Maybe you've been sick for so long, instead of having a ton of infectious organisms like you would expect in an acute infection, you only have a little bit. And when you only have a little bit, maybe your immune response isn't really good. Now, the other part is we can have functional or frank immune suppression in people who have been chronically ill for a while. Or if you're like me, you could have a congenital hypogammaglobulinemia where I don't make the normal amounts of IgG. So I can't always say that if you test me with an IgG, that it's going to be an accurate test. So there's a lot of little nuances that need to be understood because your immune system is critical in allowing these antibody tests to work. So one of the big problems we run into is we make the assumption that the person being tested has a fully functional immune system, and most docs don't check. I do. The people that I train in the Lyme Practitioner Training Certification Program, they also know this too, and they check. So the next thing we need to talk about is antibody variability, right? Everyone's assuming that with these antibody tests that every single person we test is going to be like the next person. But that's just not the case with Borrelia infections. There's a pivotal study that came out of Monica Ember's lab at Tulane in 2017, where they found significant antibody variability before, during, and after antibiotic treatment of rhesus macaque monkeys. Now, one of the things that we saw was that different individuals produced highly variable antibody responses, both between individuals as well as within individuals when looking at different types of antibodies. So not everyone makes a 23, not everyone makes a 39. Some make more or less during and after treatment than they do before. Some never respond at all. Now, the thing is, you have to understand, we know these animals are infected because we did it to them. And at the end of the study, they looked at them to see if they had viable organisms, and they did. It wasn't like they just cured themselves. So this is a huge problem, right? Because this variability means that standard sort of narrow spectrum testing methodology of old really is super outdated. And that's one of the reasons that it fails to detect Lyme disease. And these findings really highlight why we need to use multi-strain, multi-species immunoblots to start looking for the true positive people so that we're not missing people. One of the things that we see with Igenex is that in their IgM band, they're looking at 26 different proteins. Some of them are repeats, but so if you get 123 positive or 323 positive, your 23 is only called positive once. But if we're missing because we're not looking at all the strains, then Igenex's immunoblot is going to pick that up. And in the IgG world, they're actually using 31 different strains. So if you compared that to, say, your normal Quest test or any other CDC two-tier style Western blot, we're going to look at 3 for IgM. They're all going to be based on that B31 strain, and then 10 for IgG, all based on B31. Now, while that's included in the Igenex blot, they've gone way beyond, right? Rather than 3 IgM, they're doing 26. And rather than 10 IgG, they're doing 31. And all the repeats, they don't make you double positive, but they do confirm it. And they also make sure we're not missing. So it's very important to look at multi-strain, multi-species when we're actually in clinical practice. And the thing is, like, why get the diagnosis wrong? Don't your patients deserve better? I mean, how many people have you spoken to? Like even myself, I got diagnosed with Lyme, treated for 10 days, was sick for 8 years, and took almost 5 more years to get better. That's ridiculous. We don't need to do that anymore. But this is why we're making this video. This is why we're talking about these different things, is to understand what bands are truly positive in Lyme disease and also make sure that your patient is getting the right ones. So if you're seeing Lyme patients and you don't feel 100% comfortable with interpreting these lab results and then making those critical clinical judgments that help you make the diagnosis and then go forward with appropriate treatment to help alleviate your patient's suffering and help them recover their health completely, then you owe it to yourself and to your patients to upgrade your knowledge base. And that's exactly why I made the Lyme Disease Practitioner Certification and Mentorship Program, because it took me nearly a decade to feel really comfortable. And with so many people suffering so much from Lyme disease and all these other co-infections, there's not enough time and there's not enough people. So the LDPC has been designed to help people essentially go from 0 to hero in the Lyme disease and co-infection world in under a year. And most people are feeling tremendously more confident in 4 to 6 weeks because this program is designed with in-depth knowledge and a structure of learning that helps busy clinicians get their level of knowledge way up very quickly and easily, and provides you with the direct mentorship with your own patient cases so you're not out there doing it alone. So I just wanted to summarize some of the most critical takeaways that we've talked about today. One is you need to be able to see those Lyme-specific bands clearly, and you need to be able to learn and understand how to trust them clinically. Also, we want to make sure that we are ordering the right test, right? We want to make sure if someone has a high likelihood of Lyme, then we should be getting them the proper testing and not relying on testing strategies that are over 30 years old. Now, if you happen to need to start with one of these arcane old labs, well, hey, sometimes you're going to get a Lyme-specific band that really can help support your diagnosis. But if you do get a blot and in a person who really, your spidey sense is telling you they got Lyme disease and it's, the results are unclear or even completely negative, then if your clinical suspicion remains high, this is a time to reach out Learn more about more specialty testing and order the correct one so that you can actually nail down that diagnosis and finally help that person regain their health. Now, I want to remind you something that one of my mentors, Dr. Charles Ray Jones, taught me in the very beginning. That's that Lyme disease is a clinical diagnosis supported by laboratory data, but the labs do not replace your clinical judgment. In my over 15 years experience in this field, and I've been in medicine in one way or another for over 30 years at this point, the most significant Lyme disease mistake isn't the false positive test. It's the countless true, real infections that are missed by using outdated tests and outdated interpretation strategies. So when you understand Lyme-specific bands and you use higher definition, multi-species, multi-strain immunoblots, such as the testing at Igenex, now we can start to really understand how to correct those problems and start to really give our patients the diagnosis and the treatment that they deserve. If you found this deep dive helpful, please smash that like button below and subscribe to the channel. It helps us out tremendously, costs you nothing, and I want to make sure that you're the first person to know when we drop new practical insights for patients and practitioners and provide more practical insights on Lyme disease and chronic illness recovery. And please drop a comment below. Let me know what you liked about this video, what other parts you'd like to know about, and tell me, what other topics you'd like to take a deep dive into with Lyme and other tick-borne co-infections, other environmentally acquired illnesses, because I want to make sure that we get the best science and the best art in your hands so that you can help your patients get better as quickly as possible. And clinicians, one other thing, check out the additional training resources linked in the description below to help you sharpen your Lyme disease and tick-borne co-infection expertise. And if you're a clinician and you'd like a copy of my Lyme disease bands cheat sheet, where I review all the highly specific bands and their importance in Lyme diagnosis, then please comment cheat sheet below and we'll send that right over to you.